Hi there, this is Dr. Avinash. Welcome to chapter number 44. I presume you have already done my previous video wherein I speak about the drugs used for bleeding, controlling bleeding and clotting. This video is all about substances that are required for blood formation and are used in treatment of anemias. Now, the main drug that you have to do from this chapter is iron. Okay. Certain things I'll tell you for your information sake. Certain things are from exam perspective. Like for example, the distribution of iron in the human body. You need to know this. Iron is very important. The total iron in an adult is around 2.5 to 5 gram, average of 3.5 grams, and it is slightly more in males as compared to females. Out of this iron, 62% is in hemoglobin, as iron stores in the form of ferritin and hemosiderin, it is 25%. As myoglobin in muscles, it's 7%, and other parenchymal iron is 6%, something like enzymes and cytochromes and so on. Okay, hemoglobin that we are talking about is a protoporphyrin ring. Each molecule of hemoglobin has 4 heme residues, and each heme contains 1 ion. So there will be 4 ion in each hemoglobin molecule. Okay. So compared to the weight of hemoglobin, it only has 0.33% iron. So when someone loses 100 ml of blood, around 50 mg elemental iron is lost. Conversely, it means that to raise the hemoglobin level of blood by 1 gram per deciliter, you have to give at least 200 mg of elemental iron. Okay, now this is important because we are going to use it while calculating the amount of iron to be given while treatment. Iron is stored in ferric form in combination with a protein called as apoferritin. So apoferritin plus iron gives you ferritin. If ferritin is not utilized, it starts getting aggregated into hemosiderin, and hemosiderin is kind of permanent, it is not used. Okay. Now this is what is important. You need to know this. You also have to understand that ferritin gets saturated to different extents. So sometimes it can be 5% saturated, 10% saturated. At full saturation, it can hold 30% iron as compared to its weight. And where is iron stored? In the reticuloendothelial cells. This is the most important site. Apart from that, iron is also part of cytochromes, peroxidase, catalases, xanthine oxidase, many mitochondrial enzymes. Okay, so when we say that somebody is suffering from iron deficiency, the first thing that comes to our mind is iron deficiency anemia. But you have to realize that all these enzymes are also going to suffer. So basically all cells are going to get affected. RBCs getting affected is the most common presentation. That's it. So how much iron should you be taking? An adult male should be taking 0.5 to 1 mg of iron every day. Female 1 to 2 mg. Now see, the demand of a menstruating adult female is higher because she is losing iron every menstrual cycle. Infant needs 60 microgram per kg. Children need it at 25 microgram per kg, and in the last 2 trimesters of pregnancy, you need around 3 to 5 mg of elemental iron. Simple. Where will you get it? Well, non-veg sources are great. So are dry beans, dry fruits, wheat germ, yeast. A medium source is meat, chicken, fish, spinach, bananas, apples. Milk products, root vegetables are very poor sources. Simple. Let's talk a little bit about the absorption of iron. The absorption is very easy to understand when you understand the fact that the food iron is actually present in 3 distinct forms. It is present as heme, non-heme Fe3 plus, and non-heme Fe2 plus. So 3 ways in which we can have iron in our diet. Okay, the heme iron is not at all an issue. there is a special transporter called as heme transporter which can absorb the heme ion present in our food. The ion will be removed from that heme and it can be utilized by the human body. Fe2 plus is not a problem because we have a special transport protein called as DMT, divalent metal transporter number 1. This DMT1 helps in absorption of Fe2 plus. Fe3 plus ion cannot be absorbed the way it is. It has to be first converted into Fe2 plus. Luckily, the iron in our stomach helps us convert Fe3 plus into Fe2 plus. We also have some duodenal cytochrome B enzyme which can convert Fe3 plus into Fe2 plus, and then the Fe2 plus is absorbed. So there are only two ways of absorbing iron, heme and Fe2 plus. Fe2 plus goes by DMT, divalent metal transporter number 1. Simple. Once inside the duodenal epithelial cell, depending on the body's store of iron, how much iron is present in the blood, the iron might really be sent into the blood or it will not be sent into the blood and stored in the form of ferritin. Say for example, a person has low blood iron. The body needs iron. So a special protein called as ferroportin 1, this is a transport protein for iron, works on the basal side of the duodenal epithelial cells and takes all the iron that has been absorbed, the Fe2 plus iron, and puts it inside the blood. The moment it is on the basolateral side, not blood really, in the interstitial space just before it enters into the blood, we have another enzyme, hafestin, which converts it into Fe3 plus. Fe3 plus goes into the blood and it joins with plasma transferrin, and then it is taken to the RBC production center, to the liver, and so on and so forth. Imagine there is enough iron in the blood. If there is too much iron in the blood, that excess iron stimulates liver. The liver makes a protein called as hepcidin, and hepcidin inhibits ferroportin 1. So when there is enough iron in the blood, via liver, hepcidin, ferroportin shuts down. So iron remains inside the duodenal epithelial cells in the form of mucosal ferritin. Our intestinal cells gets replaced literally every day, every other day. So when this epithelium is lost by shedding, this extra mucosal ferritin is also lost, which means if your blood does not require iron, it doesn't matter whether you eat iron in your diet or not. If you eat iron, it will not get into the blood. If there is enough iron in the blood, no more iron absorption will take place. But if there is less iron in the blood, then that iron is preferentially used for production of RBC. Iron does not become spare for liver. Liver not getting iron is equal to no hepcidin, and no hepcidin is equal to functional ferroportin. And in such a scenario, iron will be put into the blood. So iron controls its own absorption. If you have understood what I have said till now, you would have realized that the mucosal epithelium of the duodenum is like a barrier. The duodenal epithelium is like a barrier. It will only allow iron to come into the blood if required. If not required, if there is enough iron, iron cannot be absorbed. Easy. This iron which has been absorbed in the form of plasma iron transferrin combination goes to the bone marrow where RBC production is taking place. RBCs serve their purpose. Within 120 days they become old, senescent. Old RBCs go to the spleen where they are destroyed. Old RBCs can also be destroyed in the liver, and this iron that comes out of these destroyed RBC is again given to plasma transferrin, goes back to the RBC. It's kind of, recycling happening here. Only when there is excessive iron in the blood, that hepcidin synthesis starts and it inhibits the inhibits the intestine, the duodenum, from absorbing iron. Is it simple? Cool. Now, please understand that infections and inflammations can also stimulate the liver indirectly by making interleukin 6 and lipopolysaccharide. The gram negative bacterial cell wall is called as lipopolysaccharide, right? So these gram negative organisms, this inflammatory mediator called as interleukin 6, it can also stimulate hepcidin synthesis. And you know what hepcidin does? Stops the absorption of iron, which means any person who has chronic infections or chronic inflammation will have hepcidin synthesis, will have difficulty in absorbing iron, and as a result, such people will end up with the anemia of infectious disease. Very easy to understand? Clear? Now, with this in mind, let us talk about factors that positively enhance the absorption of iron. Acids, all reducing substances, will convert Fe3 plus into Fe2 plus. Fe2 plus is easily absorbed, Fe3 plus is not absorbed. Simple. Meat is a rich source of heme iron. Heme iron has a different transport protein, it can be absorbed better. But there are factors which can retard iron absorption. For example, alkalis, they do not convert Fe3 plus into 2 plus. They actually convert Fe2 plus into Fe3 plus, stopping the absorption of iron. Phosphates, phytates, tetracycline can react with iron and decrease its absorption. Plus, food and stomach also interferes with iron absorption. That's the reason why when you recommend an iron tablet, oral iron tablet, you should recommend the patient to take the tablet on empty stomach or at least 2 hours after meal, so that food does not interfere with the absorption. Another good trick would be to give iron with a little lemon water. The lemon water acid will convert Fe3 plus into Fe2 plus, helping absorption. Easy. Now, the elemental iron content is important in the tablet that you are giving. It's not a quantity of iron compound per dose. How much elemental iron will be available? That is supposed to be taken into consideration. A total of 200 mg elemental iron given in 3 divided doses will give you the best RBC producing response. 200 mg per day, 3 divided doses. 200 divided by 3 doses comes to around 70 mg. But if the person does not have iron deficiency anemia and you are taking this medicine as a prophylaxis, you are giving this medicine as a prophylaxis, then 30 mg iron daily is sufficient. Don't overload iron, otherwise you will get some side effects. Actually, even at normal doses you get these side effects, such as epigastric pain, heartburn. This is because of acidity caused by iron. Nausea, vomiting, bloating can happen, and abdominal pain or colic has been reported. With syrups of iron, staining of teeth is a common problem. Metallic taste can also be a problem. Iron is constipating in most people. Okay, but sometimes iron irritates the GIT to such a level that it can cause loose motions. So constipation is also a side effect, diarrhea is also a side effect, but constipation is more common than diarrhea. Should you give injections of iron then, if these many complications, if these many side effects are there? No. Parenteral preparations are reserved for those in whom oral iron is not tolerated, there is too much of bowel upsetting. Okay, or we have given oral, the patient is taking oral tablets of iron and yet that iron is not getting absorbed. Maybe the patient has iron malabsorption syndrome or inflammatory bowel disease. Maybe the patient is not eating iron tablets, non-compliance, or there's severe deficiency and chronic bleeding. In such a case, you can't wait for the iron to get absorbed, you need to deliver iron directly. We also give parenteral iron in all those people who we have given erythropoietin. See, the moment we give erythropoietin, the production of RBC is going to increase drastically. When you have increased production of RBCs, you need to provide raw materials also. Iron is one of the important raw materials. The parenteral iron therapy has to be calculated. You can't randomly give any number. The calculation is very simple. 4.4 into body weight in kg into Hb deficit in gram per deciliter. That much mg of iron is required. I'll give you an example to make things clear. Imagine the ideal hemoglobin is 15 mg per deciliter. Okay, this much is ideal. Imagine you have a patient who has iron deficiency anemia. Okay, his hemoglobin is 10 mg per deciliter. So how much is the deficit? 15 minus 10, total 5 mg is the deficit. So Hb deficit will become 5. Let's say his weight is 60 kg. So the formula becomes 4.4 into 60, because that's his body weight, into Hb deficit, as we just calculated, it is 5 mg per deciliter. Now if you calculate this, the total value will come to 1320. This is just a calculation. You can pick out your take out your calculator and do this. It's very easy to understand this calculation. And this much is the mg of iron this patient requires, not only to cure his anemia but even to replenish his body stores. Simple, easy. So we are calculating both deficit and body stores. Both will be taken care of by this particular dose. The following medications are important from your exam perspective and from your clinical perspective. The first is iron dextran. This is a high molecular weight colloidal solution. It contains 50 mg elemental iron per ml. This is the only preparation that is injected IM as well as IV. Important MCQ, you must know this. When you are giving this, you have to remember that almost 10 to 30% of whatever you inject IM will remain bound to the local tissue. So if you are giving, let's say, 1000 mg, only 750 mg will actually enter into blood. The remaining 250 mg will remain stuck to the muscular tissue. And that's the reason why when you calculate the dose, as on the previous slide, you need to add extra 25% to the calculated dose so that you take care of this locally bound iron. Iron dextran is painful. If not given properly, it will stain the skin, and it is known to cause sterile abscess. Sterile abscesses are abscess or pus-filled cavities without any bacteria. So iron will kill the muscle cells, and it will cause an abscess formation. Once it reaches the blood, it can even cause fever, headache, joint pain. The entire body can become red. Flushing will happen. The person can feel his own heartbeat, palpitations, chest pains can happen. Dyspnea, lymph node enlargement are common signs. Very, very rarely we have noticed anaphylaxis like anaphylactoid reaction, which has led to vascular collapse and death. To prevent the staining of skin, we use a special technique called as the Z-track technique. As you can see in the diagram given here, before you inject, you pull the skin away from the injection site and then you inject. Getting it? When you release the skin, look at the track so formed. It is zigzag. Right? The track goes like this, and as a result, the iron that has been deposited either in the muscle basically, does not come back near the skin and does not stain the skin. So this is a good strategy, the Z-track technique. The second preparation of iron that we need to know is iron sorbitol citric acid. It is a low molecular weight complex. It can only be given IM, only IM. It is absorbed easily into circulation, but 30% of it gets wasted in urine, which means the urine will get ironish color. It will turn brown. You have to warn the patient, otherwise the patient will become really worried. Why is this urine turning brown? The next is ferrous sucrose. It's newer. It is high molecular weight complex of iron hydroxide with sucrose. When given by IV injection, it is picked up by the reticuloendothelial cells, and then there is a slow gradual release from the RE cells. Okay. It can only be given IV. This is because the solution is highly alkaline. An alkaline solution, if you give in the muscles or in the subcutaneous region, then it will cause necrosis. So you give it IV only. So iron sorbitol citric acid is IM only, ferrous sucrose is IV only, and the one which we studied here, iron dextran, is both IM and IV. Easy. Oral iron should not be given along with ferrous sucrose until 5 days after the last injection. So you start iron after 5 days if you have to start iron. Simple. The next medicine that you need to know is ferric carboxy maltose. This is the latest preparation of iron. It has a ferric hydroxide core and it is covered by a carbohydrate shell. When injected, it is taken up by reticuloendothelial cells, primarily in the bone marrow, in the liver and the spleen, and that's how the production of RBCs increase. Now you can't overdose these medications, otherwise you will get acute iron poisoning. Okay, there's only one antidote, desferrioxamine. For this, we will have a look at our textbook so that everything is clear. Now, my entire explanation till now was about iron absorption, factors affecting iron absorption. So I gave positive and negative factors, the mucosal block or the ferritin curtain or the mucosal curtain theory that we spoke about, of how the mucosa will not allow unnecessary iron to get absorbed. The transportation, utilization and storage can be done as a one read topic. It's not really important from your exam perspective. And as far as oral iron preparations are concerned, I have already spoken. Not really important what drug you give, it is how much of elemental iron is important. We have spoken about the side effects. Oral iron would not be asked, I don't expect it to come. But for the sake of MCQs, have a look at carbonyl iron. Okay, this is only from your exam perspective. We have also spoken about all the side effects that happen. How much should it be given? So basically we have touched all bases here. Okay, so please remember adverse effects of oral iron. We moved on to when to give parenteral iron therapy. We understood the calculation. Okay, we also spoke about the medications, iron dextran and all the others. Please go through this. The uses I have not really mentioned because it's such a logical thing, right? Iron deficiency anemia. This will be the most important indication for medicinal iron. Actually, iron deficiency anemia is the commonest anemia, especially in developing countries where most of the population is anemic. The RBCs in iron deficiency anemia are microcytic and hypochromic. Okay. Remember, we also spoke about how iron also is present in so many other enzymes, right? So there will always be other effects, so you have to be careful of giving this iron only in iron deficiency anemia. You look out for all the other symptoms also. Okay, we also spoke about how chronic bleeding from GIT is also one of the cause. So you have to take care of the causative factor also. If somebody has hookworm infestation and you keep giving iron, it is not going to work. Similarly, if somebody has repeated attacks of malaria or chronic inflammatory disease, then he will not be recovering because of your oral iron. You have to treat the real cause. Okay. Remember, to give iron orally, parenteral is only for special circumstances. Within a week's time, the hemoglobin level should start rising. 0.5 to 1 gram per deciliter per week is a good response to iron therapy. Actually, the hemoglobin starts becoming better early on. Later on, it might just the rate of increase might decline. But you continue giving this therapy till the hemoglobin becomes normal, plus 2 to 3 months more after, so that even the stores are replenished. We spoke about how prophylaxis is important. Iron balance is much more precarious in menstruating women, and hence they might be given iron later half of pregnancy, early infancy is where you give it. So, and other diseases where there's kind of bleeding in place, you can give it, or where there's anemia, you can take it. Even in megaloblastic anemia, after you give vitamin B12 or folate, you can add iron. The idea is very simple. If a person is deficient for vitamin B12 and folate, the person is as well deficient for iron. So you first correct megaloblastic anemia, and as that is getting corrected, you will also add iron, otherwise iron deficiency might get unmasked. Which brings me to acute iron poisoning, the last topic from this particular chapter. This occurs mostly in infants and children. The reason being, these tablets are so beautiful looking, beautiful red in color. 10 to 20 iron tablets or equal amounts of liquid preparation, like that is more than 60 mg per kg of iron, will cause toxicity. Adults will not eat so much iron, so it's rare. The person comes with history of vomiting, abdominal pain, vomiting blood, hematemesis, diarrhea, lethargy, cyanosis, dehydration, acidosis, convulsions, shock, cardiovascular collapse, and death. Sometimes as early as 6 hours, but typically it is delayed to around 12 to 36 hours. Actually, there is a time period in between where the child appears to improve a little bit. Okay. What is happening is the excessive iron is causing hemorrhage and inflammation in the GIT, and it is progressing, so it can even go right up till necrotizing enteritis, hepatic necrosis, and it can even cause brain damage. So earlier you manage, the better it is. How do you treat any poison? By stopping absorption first. So we can induce vomiting or perform gastric lavage with soda bicarb. The sodium bicarbonate makes Fe2 plus into Fe3 plus. Fe3 plus is non-absorbable. So that is one way. We can even give egg yolk and milk. This also binds to iron and makes it non-absorbable. Charcoal and all does not work, so don't waste your time. What about the drug that is already in the blood? Here comes desferrioxamine. This is to be injected IM, 0.5 to 1 gram. Repeat 4 to 12 hourly as required, or if you are giving IV because the patient is in shock, 10 to 15 mg per kg per hour, max of 75 mg per kg in a day, till iron starts to fall below 300 microgram per deciliter. The earlier you start the therapy, the better it is. Otherwise, this iron would bind to different tissue components, and then it will become really difficult to manage. You can even use DTPA or calcium editate if desferrioxamine is not available, but never use British anti-Lewisite BAL. Apart from that, please give supportive measures, which means maintain fluid electrolyte balance, correct acidosis by giving necessary IV infusion, take care of airway, breathing, circulation, blood pressure. If convulsions are there, diazepam. So basically the general things you have to take care of. In this chapter, you need to do this much properly. Now, there's a latest new preparation that has come in the market, which is this one, iron isomaltoside 1000, latest injectable IV formulation. From 2016 it has started coming in the market. It consists of iron that is bound tightly to matrix of isomaltose or isomaltoside, actually 1000. It's an oligosaccharide. The 1000 means the molecular weight. The idea is very simple. Give it IV. It will be taken up by reticuloendothelial cells and slowly released. Okay. Now, because this iron is bound, there's tight binding within the matrix of this medicine, that iron is not so easily available for causing toxicities, and that's the reason why toxicity is less, and you can give higher doses also. Okay, so what used to happen in previous medicines that we have said, we had to give it in parts so that toxicity does not happen. So 2 or 3 infusions had to be given sometime. Here, single short period IV infusion is amazing because the patient has to come once, cost savings, multiple exposures to IV iron, injections, syringes is all avoided. So it's very, very good. Okay. If the patient does not want a continuous infusion for like full dose, then 100 to 200 mg IV every single day can be given in 5 minutes. Okay. It's efficacious. Efficacy is good. Okay. This is how much you need to remember. That's that. If you do this much, it's more than sufficient. I hope you have got everything from this chapter. This is it for this video. I will see you in the next one. Till then, take care. Keep rocking. Bye.